Hello, everyone, and welcome. Welcome tonight. If you're comfortable, everybody can turn their cameras on so I can see you. That would be helpful as well, and then I can see everyone. If not, you're comfortable that way as well. So hip hip hooray! I am your host, Braden Kipp. I'm a registered physical therapist and a hip rehab expert at Easthill Physiotherapy. So I want to welcome everybody to our latest installment of our virtual workshop series. So everybody, you guys said you really wanted to see it. So tonight, we're really excited to be looking at hip dysfunctions. So again, welcome. So just before we get into too much stuff, a little housekeeping. Please just turn off or mute your microphone. The button should be a red color, and that will be down in the left-hand corner. You can find that just so you know, we're not listening to somebody else on the chat. If you do want to get involved in the chat, I might ask some people sometimes, feel free, that's how you chat, and you can turn that on when I ask you to. And then try not to press the present now button. And then when you send a chat message, you know, click that little one in the right-hand corner and type your message in the box in the lower right-hand corner. So everyone, all attendees are going to get their name put into a random draw for some free Easthill Physio sessions. So who wants to win a free session with one of our amazing physios? If you do, type win in the chat box, okay? I want to see that. Type win. Win. Caroline. Yahoo. Dave. Sandra. Yes, everybody wants a free session. Well, fingers crossed, so we'll see. Okay, awesome, Linda. So before you know, we get into it, I just had a joke to loosen everybody up. So what do you call your hip when it's in extreme distress? Does anybody have an idea? So your hip when it's in extreme distress, I gave you guys a little clue at the beginning. Any ideas? So when your hip is in extreme distress, raise the hand, go for it. Yeah, if you want to go on mic, go for it. Donna. Tragically hip, yes. Yes. Irvin, I love it. Caroline, awesome. Yeah, the tragically hip. I just wanted to give a shout out to the tragically hip and 𝗀𝗶𝗽, obviously. Rest in peace. So yeah. So tonight, you guys are going to find out how you can stay hip. You're going to get tired of all my hip puns and jokes by the end of this one, so bear with me. So yeah, find out how you can stay hip. Tonight we're going to look at if your hip or pelvic symmetry or asymmetry is the cause of your pain or dysfunction. We're going to look at the 4 most common causes of hip pain, those being osteoarthritis or OA, greater trochanteric pain syndrome, GTPS, femoral acetabular impingement, FAI, and then referral from the lumbar spine or lumbar radiculopathy. We're going to go through a guided self-diagnosis to help you identify what is causing your own hip pain tonight. I think everybody's pretty excited. It's my first time going through a full diagnosis of this many people online, so let's see if we can do it. And then we're going to go through some behaviors that can cause your hip pain or make your hip pain worse. So I want to know, I want to take a little poll before we get started to kind of know what kind of hip dysfunctions or hip pains or what everybody's dealing with tonight. So I want to take a little poll before we get into too much stuff. So to take the poll, there's a little like triangular button in the lower right hand corner. You can press that and you can go to polls and you can take the poll. So I'm just going to get the first one going here. So what does your hip impairment limit you from doing? So I want to see, does it limit you from putting on your shoes or socks, getting in or out of a vehicle, walking, running, sitting, standing for prolonged periods? So I'll give you guys a few seconds to answer that poll. Walking, running. Sitting and standing have a healthy lead here. Putting on some shoes and socks as well. Okay, sitting, standing for prolonged periods of time. Okay. Okay. All of the above. Okay, Dave. Yeah, I get you. Okay. And then the next one. When does your hip pain affect you the most? 30 minutes to an hour on waking in the morning? At the end of your day? When trying to sleep at night? Or after physical activity? Let's have a look at these ones. Yeah, all around. Morning, night. Okay, yeah. After physical activity. After skiing, lying on my side in bed at night. Karina, we're going to help you with that. You're going to learn a lot. That's going to go away. I guarantee it. Okay. Yeah, a lot with physical activity. I like to see how active everybody is. That's good. Okay. And a lot of sleeping. Sleeping, you know, it's one of those things we can modify a little bit for you guys. And hopefully I can teach you a few tricks that you can try to maybe be able to improve your sleep hygiene or get some better rest. After activity, okay. Okay, let's do another one here. Okay, the next one, I'm going to launch it here for you guys. Where is the location of your pain? Is it the anterior or like the front of your hip? Is it lateral side of your hip? Posterior buttock, or does it even go into the groin? I want to know. Twist and bend simultaneously, Valerie. Okay. A lot of posterior buttock area pain, hey? Lateral side, anterior front of the groin, sometimes hip flexor into the groin. Okay. Yeah, interesting. So it sounds like we got a few different kind of conditions here that we're gonna work through tonight. And then I want to do one more poll here. Last one. Does your hip ever snap, catch, lock, or give way? Does anybody have any of these issues? Sometimes it's an audible snap, sometimes you can feel it. Giving way. Locking, yeah. Snapping, yeah. Okay. Yeah, so we got a good group, a good mix of pathologies, I think, tonight. So the reason I do this is just to kind of get an idea of, you know, what is people's issues, what's kind of going on. So, yeah, so thanks for doing that for me, you guys. Okay. So type in the chat box. So you can use the chat like we talked about earlier. If you had no hip issues right now, what would you be doing? Or what is your hip issues stopping you from doing? Pamela says running. Sleeping well, Jen, yeah. Hiking. Walking, work out more, trail running and hiking. Walking, sitting and watching a movie from start to finish. Walking a long distance. Running is impossible. Cross-country skiing. Yeah, hiking, snowshoeing. Running. Slows me down, but I try to push through the discomfort. Skiing, weakness, yeah. I want to put somebody on mic. Let's see. I want to know more about what's going on. Let's see. Who wants to go on mic? Raise their hand, or just go on mic if you want to. I want to know about what's going on with your hip. Maybe somebody that's hiking or skiing. What about Lucy? Lucy Dillon, are you able to go on mic for us? Are you comfortable doing that?
Okay. Okay, can you hear me?
Yeah, awesome, Lucy. Nice to meet you, by the way.
Same here.
So hiking's a bit of an issue, you say?
For me, yes, because if I'm walking for a long period of time, the hip will lock up or give way, so you can't do that. I can't do it anymore like I used to do it.
Yeah. Okay. So, you talk about walking or hiking. Why is that? Why is that important to you?
It's my out, so I like to be outdoors. And if I can't be outside, then I feel trapped in the house. Yeah.
Feel a little isolated, as like all of us do, especially with COVID times and stuff, hey?
Right.
I feel you. I bet a lot of us have that issue too. I bet everybody on here can kind of relate to that. So let me ask you this, Lucy. With your hip issues, what have you done so far to try to help yourself or try to fix it?
After doctors and x-rays, I've been going to Easthill for physio.
Awesome. Shout out. I like it.
Okay, there you go.
Awesome. Who do you see at Easthill? I'm curious.
Alex.
Awesome. Alex is great.
Yeah.
Well, that's good. You're getting some help then, hey? How's it been with the physio?
Oh, it's good. But you have to stick with it.
That's right.
Yeah.
You're preaching to the choir. I like it, Lucy. I see this a ton of times, guys, with some hip issues just similar to Lucy's. Thanks for going on mic there for us, Lucy.
Thank you.
And I've had quite a few individuals. There was a lot of skiers. I was going to mention I've had a lot of skiers come in and snowboarders, that came in with hip issues before the ski season, and we were able, just like Alex is helping Lucy, to help figure out those hip issues, and we were able to get them back on the slopes and enjoying some of that champagne powder. So I see this all the time. Yeah, we'll help you guys out. All right, okay. So. I want to go through this hip anatomy asymmetry kind of stuff, okay? So the first one on the left, so we're kind of looking at where the hip sits, all right? So we call it an anteroversion or retroversion. So it's pretty normal to have some degree of rotation of the head of the femur. However, if it sits like too far forward or too far backwards, this can cause like a bit of a pinching of the head of the femur in the socket or the acetabulum, right? So think about your hip as a ball and socket, and usually it sits right centered in there. Sometimes what can happen is that the hip can become twisted or come forward a little bit or come backward a little bit, and this can cause some asymmetry into that hip, okay? And that's not such a great thing. It can lead to further wear and tear. It can lead to muscle imbalance, especially dominance of the TFL or the tensor fascia lata, kind of the muscle that goes on the outside of the leg here, and then over the iliopsoas or hip flexors, right? So it creates that bit of a muscle imbalance. And the second picture in the middle that we're looking at hip centering. So if, like I said, if your hip doesn't sit in the center of the joint, it's going to cause more wear and tear on there, right? Especially for us that are, worried about further like progressing their injury or their osteoarthritis, perhaps. If you don't have the muscle control to keep the head of the femur centered within that acetabulum, within that socket, like activities, can cause an abnormal path of that center of rotation. So normal activities where it would just rotate in there, instead it would abut or bump up against the socket in there, which can lead to more unwanted wear and tear and early osteoarthritis. So this is something as physios that we look at all the time, and I'm hopefully going to teach you guys how to be able to do this at home on your own. And then the last picture on the right, we call it coxa valgus or excessive hip adduction, or like a Trendelenburg, if you've ever heard that. So basically what that is showing is that the angle of the hip when standing on it, there's an increased angle. So think about the angle being from your hip down here like that, okay? So instead of having nice and straight in that load, that weight bearing through there, it's kind of angled. It can progress, it can get knee things as well, but it can put a lot of load onto the hip, right? So that excessive hip adduction can lead to, again, an overactive TFL. So kind of the muscle out here that we had been talking about earlier. And IT band, making it tonic, rigid, and putting more compressive forces on their trochanteric bursa, and that can cause you pain. So furthermore, with those, the glute med and glute min can become long and weak, and not do its job. And over time, this breakdown can cause gluteal tendinopathy. So I hope you guys, it's kind of hard to see there, but you can kind of see if it was to, right in this one, if it was to sit more forward, all these glute muscles become long and weak and they'd be sleeping on you, not doing their job, okay? So I want to know, type in the chat, what day-to-day activities make your pain worse? Like activities of daily living, is it, sometimes getting out of bed? Is it, standing in the shower? Is it, walking to work? What is it? Type in the chat. Going upstairs, walking. Driving up to the star, Rob, yeah. Driving, that's sitting for a while, hey? Yeah, getting out of the car, standing from a sitting position, laying in bed. Cross-country skiing, standing on uneven ground. Standing, sitting for long periods of time, driving. Yeah, Irvin, yeah. Putting my socks on, tying shoes. Sitting for too long. Yeah, there's lots of these daily activities, and sometimes it's a very debilitating thing. Other times it's just one of those things that's very naggy and annoying. And I'm hoping I can help you guys get rid of that kind of stuff, and you can get back to doing those activities a bit easier, a bit more pain-free. Gate skiing, Karina, yeah. Okay, so here we're going to go through the most common causes of hip pain. So the first one is osteoarthritis, or OA. It's a degenerative condition. It's caused by mechanical overload by a weight-bearing joint. So it's not just the hip that can do this. There's other joints that can do this, but we're specifically talking about the hip today. It mainly affects the articular cartilage of the joint. So that's kind of like what lines that socket, okay, or that femur head. But it can affect the underlying subchondral bone, the synovium, and the ligaments in the joint capsule can get affected as well. So what happens is that that lining, over time, it gets like some wear and tear, it gets broken down, right? So there can become some fissuring or pitting, and it actually erodes that articular cartilage, and that's what causes all the pain, okay? It leads to, over time, that's kind of with early arthritis. After it progresses, there gets to be some thickening and sclerosis or inflammation of that subchondral bone. And then this can further lead to decrease of shock absorption and lubrication. So it gets dried out in there, and it's just old and cranky, right? So, after you lose that function, then, there's bone-on-bone activity, and there's leads to a bit of an instability, and it forms what we call an osteophyte. So that's like a little bony spur, right? And that can, just think about if it's grinding or rubbing on each other over time, that spur is going to build up, and that's maybe sometimes when people that were saying you get that catching or that locking, that can be from that sometimes. So some risk factors with OA is obviously it's a weight-bearing thing, right? So if we have more weight to lug around, like if we're put on a few pounds from the holidays, as many of us have, or obesity, that kind of thing, that can put you at further risk for arthritis. If you have some muscle imbalances, like we talked about, or weakness. And then those of us that, with our daily activities or occupations, if we're repetitively loading those joints. But actually the worst one, more than just loading it, is inactivity or sedentary. So if you're not doing anything, that's actually worse than if you were to, be doing activity. Okay. The second one is greater trochanteric pain syndrome. So this one, it arises from the pathology of the bursa and the tendons. We used to think it was actually just from a compressive friction and inflammation of the trochanteric bursa, which you see, it's that little purple one right in there. That's the one that kind of gets compressed. That's what we used to think caused all the pain and stuff there. However, now it's more, it's better understood that most cases of trochanteric pain, they demonstrate some evidence of gluteal tendinopathy. So it's not just the bursa, it's actually the glute med and glute min muscles, the tendons that run over top of it. they get broken down over time, and they can't handle those loads anymore. So, you know, the bursa may be involved, but it's not without the glute med or glute min tendons being affected. So that's, you know, that's where a lot of that pain comes from, is a tendinopathy. Okay. So with tendinopathies, you know, they can range from severity. You know, it can be small little micro traumas that you wouldn't even be able to pick up, or, you know, there's just little aggravation, to a full grade 3 tear where it's fully torn off the bone, right? So there's variations, and then anywhere in between that. Okay. So, you know, where those tendons insert on the greater trochanter there and the IT band, again, the bursa is vulnerable to the compression and the friction by the overlying tendons in the IT band. So those of you that they said they had some snapping earlier, this is a kind of a clue for you guys. If you have that audible snapping in the hip, it's basically the IT band is running over that greater trochanter and snapping over that. You know, if you have that in the outside of the leg, from when you move from that, when you move from an extension to flexion position, it will snap over that sometimes. So those of you that had some walking or running kind of things, or skiing for that matter, those kind of things. So over time, those tendons, they get broken down. They can't handle that normal force or that excessive load anymore. And then they get weak, and then you lead to dysfunction like we talked about already. Okay. All right, the next two. Femoral acetabular impingement. This is a condition that occurs where there's abnormal contact between the femur and the acetabular rim. So again, that ball and socket. Okay. So there's two types, well, three types, but you can have what's called a cam impingement, or this is an abnormality on the head or neck of the femur. So you can see that middle picture where there's a bit of that osteophyte or that bony spur that forms right there after, you know, if it's wearing on that other spot, right? You have a pincer impingement. So this is an overcoverage of the femoral head by the acetabulum. So you can see that socket itself is actually extended over top, and that's where it kind of gets that pinchy sensation on. But you know what? Most of the times it's a bit of a combined nature, which you can see on the right picture. That's a little bit of both, just because they wear and rub on each other, right? So they, over time, the bone will adapt and form those little spurs or osteophytes on both of them. It's caused, like I say, by that reoccurring impingement between the acetabulum and the femur. You know, and it's basically due from repetitive micro trauma, and especially with the movement that you really notice with this one is when you're bringing your knee or your hip into flexion and then internally rotating it or getting it up into that position. That's where it really usually pinches on a lot of people's hips, if this is kind of a condition for you. You know, and furthermore, after a while, it can lead to damage to the labrum, which is basically like your shock absorber and the articular cartilage, and then it can get you, you know, it can result in early osteoarthritis. So some of the contributing factors for femoral acetabular impingement are that Trendelenburg or that coccyx valgus, that excessive hip adduction that we talked about earlier. So that can lead you to some of these this disorder. If you've had any previous femoral neck fractures, if you had like that retroversion or anteroversion where that hip's sitting forward or backward, that can lead to some of this. And then sometimes with those of us that have had childhood hip conditions like Perth's or slip capital femoral epiphysis, those can often lead to these kind of issues later down the road as well. Yeah, and then you know, it's not following that centered path. It's hitting instead of staying centered in that joint like we talked about. And then it forms an imbalance due to the dominance of the TFL over the iliopsoas or hip flexors. Yeah. So the last one I want to talk about is radiculopathy or lumbar referral. So, you know, this can be caused from damage and irritation of the lumbar joints. And it often will refer into the hips and legs as well as the back itself. So Which joints, you have 5 joints in the low back, and which joints are affected will kind of determine where the referral pain is felt. So you can kind of look at the picture there for yourself. It's quite variable. It can go into the groin, it can go into the buttock, the back, down the legs, or into the lateral or hip or front of the hip. So it kind of depends where those joints are getting compressed. So what a radiculopathy really is it's where a spinal nerve comes out of the lumbar spine, and it experiences a loss of conduction. So think about it, those of you that know a little bit about wiring or about electricians or those kind of things. It compresses it and it causes a loss of conduction. So it can cause you, there's basically 2 branches that come out. One's a sensory, so that's everything to do with feeling or touch. Sometimes you might lose feeling, or you might get some sensation changes, or you might not be able to feel some things that, and the other is a motor one. So if there's some weakness, that motor branch can be involved. But you don't necessarily have to have pain. There can be, but you don't necessarily have to have pain to have a lumbar radiculopathy. And usually it's from a compression or inflammation is the most common. And the most common kind of injuries here are if disc herniation, if there's the osteophyte on the spine, or spinal stenosis as well. And like I said, patient symptoms can vary on location, with most commonly the L4, 5, and S1. About 90% of the time it will be from those areas. Okay, I want to get you guys all involved. Whew, everybody still with me here? That's a lot to take in, but it's important to know. So I want to do myth or fact. The pain will go away. Myth or fact? Type in the chat. Fact. Myth. 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 Yeah. Yeah, so it is a myth, actually. Well, sometimes your hip pain can go away on its own. If you don't address the pain, it could lead to stress on other parts of the body, or affect your stability, or even lead to limping. So many people, you might tell themselves that their hip pain is temporary and they try to rest or stop doing their favorite activity. Well, this may provide temporary relief, but it might not actually address the underlying cause. Myth or fact? Young people don't have hip pain. Myth, 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 myth. Yeah. Yeah, good job. Myth, yeah. Hip pain can affect people of all ages. It's common in people, like I said earlier, who have childhood disease. It can happen to people in their 20s or 30s. Those usually are like kind of athletes with overuse injuries. And then it can happen in patients 30s to 50s plus. Those of us who often experience pain, due to wear and tear. Good job. And then myth or fact, hip pain is only felt in the hips. Myth, myth. Excellent. Excellent. You guys are smart. You guys know. Good job. Yeah, so yeah, myth. It can be felt in the thigh, the groin, the buttock, inside, outside of the hip, or even the back or knees sometimes. Good job, guys. Okay, here's why everybody's here. A guided hip self-diagnosis. So like I said, it's my first time trying this, so I want to give it a go with everybody. So hopefully everybody's in a spot where they can, move around a little bit in a second. So I hope you guys are excited to find out what's causing your hip issues. So let's go through it, okay? All right. So don't worry if you miss some of this, okay? We'll be sending everyone a PDF copy of this guided self-diagnosis. That way you'll have it, and then, next time you need to tell somebody what's causing your hip issues, you can look really smart and tell them what it is. All right, okay. So I want to look at the history. So we're going to look at the history first. So don't worry about the assessment or diagnosis yet. I just want to talk about the history stuff. So keep in mind what's causing your hip issues while we're doing this, okay? So the first one in the blue box this is for you if you've had a history of lateral hip pain, so pain that's going into the outside of the hip. If activity produces the pain, such as running, skiing, like that kind of stuff you guys were talking about. Lying on the painful side makes it worse. So everybody that was having that issue sleeping, lying on their side. And then the dead giveaway for this one is standing, walking, running makes it worse. Okay? So keep that in mind. The next one in the purple box. So this is pain felt in your groin or your thigh. You can have stiffness in the morning, lasting for about an hour. It's been getting progressively worse over time if you've had a previous hip injury. And then the dead giveaway for this one is if you have difficulty putting on your shoes or socks. Okay. The third one. Pain in the anterior thigh or groin, so in the front of the hip. If there's stiffness in the morning, there's pain with an insidious onset, meaning, there's not really a mechanism of injury, it's just kind of there. If you have some clicking or catching, walking and standing is okay. So that's different than the first one we talked about, right? So this is okay. And then the dead giveaway for this one is it's more painful sitting in a deep chair. Okay? Keep that in mind. And then the last one, green one. There's pain referral into the lateral or posterior hip, so the outside or back of the hip. You've had previous history of low back issues. You can have some clicking or catching. Walking and standing are okay. And kind of the dead giveaway is if your back is stiff and you don't have great range of motion for that spot, that's probably a dead giveaway for you. So I want you guys to all put that in your mind for a second and kind of think about your own condition and see which box you want to start at, okay? So we're going to go into the next part of it, the assessment, okay? So let's go for the first people with, the standing, walking, running makes it worse, okay? So what I want to do to assess this, you guys can try all of them. It's totally fine to do. If you want to try one or more, you guys feel free. So what I want everybody to do is take 30 seconds, and I want everybody to stand on one leg, okay? So I want you to stand on one leg. Try and not to let the hip drop. Just keep it level, okay? So 30 seconds like that for me. So go ahead and try that. We'll give you guys 30 seconds to stand there. And if you're like, Braden, this doesn't bother me at all. Maybe you're on the wrong leg. I don't know. You could try both, but probably you know which leg is sore. So if that reproduces your pain, where we talked about into that lateral aspect, that's a good indicator that you have greater trochanteric pain syndrome, GTPS. The other way you can test it is you can touch around in the outside of your hip, right where your hip joint is, and you can touch around in the outside of the hip. If it's really tender and sore to touch around there, another good indicator that it's greater trochanteric pain syndrome. Okay, good job, you guys. So the next one over, those of us that were having difficulty putting on our shoes or socks. So we're going to try a few. You can sit or stand. I'm going to sit so you can see me a little better probably. So what you're going to try is this. There's going to be reproduction of your pain or symptoms with rotation of the hip. So if you dangle your feet over your chair, if you externally rotate your hip that way or internally rotate your hip that way, it's probably going to be stiff and sore, a little cranky. It might reproduce your pain, okay? And then the other way we're going to test it is if you bring your knee up to your chest, it's going to be very difficult and stiff or tight or not be able to do it. So we call it a capsular pattern, meaning all those ranges of motion are a little bit stiff, but the ones flexion, internal rotation, those will be the main culprits that will be stiff, okay? So for those of you that tried that, that's probably a good indicator that you have a little bit of osteoarthritis or a little bit of degenerative change in there, okay? Okay, let's go to the next one. So those of you that found sitting in a deep chair is difficult or it causes some pain. So what I want everybody to do that was kind of thinking about this, they were in this history group. I want everybody to try a deep squat. Okay, so I want you to come down and I want you to do a deep squat all the way down. Go ahead and try that. If you find you have pain with that deep squat and it's sore, that's probably indicative of a FAR, femoral acetabular impingement. It could be something else, but I want to clarify with everybody a little bit. So, and then for those of you that feel like you're unable to do that, what you can do is also you could try this one. You could try twisting. So say it was my right hip that was the issue. If I twist towards that right side, that will reproduce my pain or make things worse. If I go away from it, it should feel better. So basically that internally rotated position, okay? And then the last one you can try again is similar, bringing your knee up and across your body into that flexed, adducted, internally rotated position. That would pinch on your hip and reproduce your pain. If you're having any of those ones and it reproduces your pain into the anterior thigh or groin, that's probably FAI. Okay, and then the last one, I want everybody to bend over and touch their toes. And if they feel really stiff and their back is sore, probably it's coming from the back. Okay, so everybody can try that, or sit in their chair and bend over. If that kind of reproduces where that pain travels, then potentially that's where it's coming from, is your low back. The other one to do is with this. It's called a slump test. So when you're sitting in your chair, what you will do is, I want you to sit up nice and tall to start, and then you're going to take the side that you have the problem with, and I want you to straighten it out and pull the toes back towards you. You're going to straighten it out, pull the toes towards you, and then when you do that, you're going to bring your head slump down towards your foot. So slump test. If you find that slump test reproduces your pain, or gives you some numbness, tingling, you feel like weakness, that's pretty indicative of lumbar radiculopathy. Okay. Does anybody have any questions so far about that? That's kind of my self-diagnosis in a nutshell. Feel free to go on mic if you have a question. Nice, you guys are smart. Good. Good. Okay. So, although, we've gone through that chart and the most common, those are some of the most, can you have more than one, Mel? Yeah, you can actually. You can have, a lot of times, OA, like a hip osteoarthritis, is from a previous, like one of those previous issues. Is it possible to have 3 and 4? Yeah, 100%. A lot of times, that's our job as physios, is trying to assess and suss out where, is this coming from your back? Is it coming from your hip? And that's our job. That's why you guys come see us, to try to help you figure out where it's coming from, right? 100%, Valerie. So yeah, like I said, as although we've gone through the chart and, those are the most common causes for hip issues, there are some other pathologies that can mimic these. So if you are unsure and you have questions, feel free to follow up, okay? You can reach out to us and we'll make sure you guys are on the right track. So I want to go through some exercises, that you guys will be able to do for each one of these conditions. So if you found out that, you have greater trochanteric pin syndrome, if you have FAI, OA, I got a whole bunch of exercises for each of you, and we'll hand them out. We'll give you guys a PDF so you don't have to remember. We'll go through a couple of them though. So this is for those of you that think they have some FAI. So, the first one I want to go through is hip capsule stretch. So it looks like the pigeon one, the top left. So what happens is that hip capsule becomes really tight, and it can push the hip forward, kind of like what we talked about earlier, where it's not staying centered in the joint. It's going to be pushing it forward. So what we want to do is loosen that up to be able to let the hip sit in a nice centered location, right? So what you're going to do is, I find it easiest to use a table or a couch, something like that. So I'll show you what it looks like. You guys can see that table okay? So what you want to do is you want to bring your hip up into this externally rotated position, and you want to try to sit back into your hip. You can lean over it a little bit. You should feel a nice stretch right into your hip joint. And that's something you can try, you know, hold it for 15 seconds, similar to what you would do for stretching, okay? One of the other ones I want to talk about is the one in the bottom center. So it's called the hip rock back. So what this does is, you know, allows you to practice, you know, that muscle control of keeping the hip centered and not letting it shift, right? So you don't want to go into pinching with this one, but rather, you know, you want to gradually work to control it before it happens and progress as you're able to, right? So you're going to go onto all fours, onto your yoga mat or your table or whatever you have, okay? I'll show you what it looks like. So what you want to do is get up onto all fours, and then if you have that pinching sensation, it starts there. That's where you go. I don't want you to go into that pinching sensation. The more you work on this and try to adjust, the better it will get. You know, you just have to progress through it. Eventually you'll be able to sit all the way back down. So hip centering. And then there's some other stretches on there. You know, we've got to stretch out that TFL and strengthen the glutes and the hip flexors, which essentially help prevent that impingement. Those are on there as well, and I'll send those to you guys, okay? So FAI people, this one's for you. Next one, greater trochanteric pain syndrome. Okay, everyone who said this. So like we talked about earlier, a lot of it comes down to the glutes, right? Or the gluteal tendinopathy, or the breakdown of those tendons, right? So everybody always, I feel like there's a misconception about how you rehab a tendon. And I hear it a lot, actually, and it's one of those things where to rehab a tendon, you have to, yes, strengthen it, but you have to do it in a gradual manner, right? You're not going to be able to go and just load it up fully. It's not going to like it. It's going to make it agitated. It's just that progression, that gradual strengthening that you have to work on, okay? So we have to work on the glute max, the glute med, and glute min. And you guys make sure you go and check out our exercise of the week video playlist. It's on our website, and you can see a recent video of, you know, how to do the bridge. There's variations, what you should be feeling, that kind of thing too. But bridge is a very easy one. There's one that I want to show you. There's a couple. It's called the Captain Morgan. It's one of my favorite ones. It's basically an isometric exercise, so it shouldn't bother it too much. It's you're not actually moving or activating that joint too much. It's more just getting that muscle. So what you want to do is you want to find a wall or a table somewhere where you can put the hip up against the wall. So you want to be able to put your hip up against the wall. And then if you can't get it up that high, that's totally fine. You can lower it down. But what you want to do is try to keep your hips level and activate that glute so you're not dropping your hip, okay? You want to keep it level. And then what you want to do is try to push that leg into the wall and hold it. Sometimes you might get a cramp or a spasm with that. And if you do, that's totally fine. Just back off a little bit. That's usually just because it's weak. Okay? So that's one of the Captain Morgans. When you do that one, I want you to hold it for 50 seconds. And I want you to do that 5 times. You can take 2 or 3 minutes in between if you need to, okay? And then for those of us that found we have some osteoarthritis, you know, we want to, you know, make sure that functional activities, you know, ensure proper alignment of the hip and the knee over the foot. And again, you guys are going to hear me a lot say this. Glute strengthening, okay? This is kind of key with the hip. It's the big muscle. It controls all that stuff, right? And then, you know, so there's some nice ones like stretching the hip flexors, stretching the rotators, the hamstrings. There's a couple functional exercises such as the sit to stand from the chair and the step ups. So with these exercises, people often have, with osteoarthritis, they have this, I call it a wear and tear bias. So what I mean by that is, they're like, yeah, Braden, this is a wear and tear injury. If I do this stuff, it's going to get worse. And I'm like, you know, it's going to progressively get worse. But remember how I said sedentary, inactive people get worse anyways? It actually prolongs the function of the joint, right? So it's acceptable to have pain levels with this, okay? I know everybody's like, yeah, Braden, I don't want to have pain, but doing these exercises, 3 to 5 out of 10 pain with exercise is actually not too bad, okay? What you do want to be aware of, if there is swelling or stiffness the following day, that's too much, you got to back off, okay? So we got to keep it functional, but we have to manage those pain expectations, right? Okay. And then the last one is for lumbar radiculopathy. So I just put a couple on here. They're directional preference exercises, so meaning one will work better than the other. So if you find doing the knee hug versus the prone press up, the numbness, weakness, or pain gets better, then you do that one. If it gets worse, try the other one, okay? Usually it's one is better than the other. So you can try those ones out, okay? You can also check out our website, you know, for our exercise of the week video playlist, like I mentioned before. And you can see the recent video for the prone press up, and it'll go through how to do that as well, okay? So just a few tips and tricks. So for those of you that had some FAI issues, you want to try to avoid sitting for too long or in low chairs or with your legs crossed over each other. You want to avoid rapid twisting movements or changes in directions. Walking, running, standing usually is tolerated pretty well, so you can continue with that stuff. You want to initially avoid activities that are aggravating to the hip. You know, you want to avoid that forced end of range of motion that we talked about, where you're bringing it up into flexion across your body, adduction, internal rotation. That one's not going to feel so good. That's just going to pinch. It's going to agitate things. Try to avoid that if you can, all right? You want to try and avoid cycling, or if you want to keep cycling, you want to try to modify that position by raising the seat height up a little bit. And then for those of you that were having trouble sleeping, this might help with this one. Trying to, when lying on your side of your hip, putting a pillow under, you know, under the hip, under this, so it doesn't let it fall into that position. That's a really helpful trick for those of you that were having sleeping issues with that one. Tips for GTPS. So you want to introduce a tendon loading, i.e. strengthening exercises, only when those initial symptoms have calmed down from resting it, okay? You want to, again, avoid crossing the legs with sitting, avoid standing with one hip popped out. I call it the booty pop, so you want to try to avoid that. That's just going to compress, cause weakness, irritation there, okay? And then you want to try to initially avoid some stairs, hills, and then running or plyometric, jumping, bounding, that kind of stuff, okay? And then tips for OA. Weight loss or reduction is always helpful. It always helps to take off some of that compression or load on the joint. Hydrotherapy is very effective. So get in the pool, get in the lake. I know it's winter, but when it gets a little nicer, get in the water and move. Low impact cardiovascular exercise is good. And then land-based exercises to promote protection of that bone density, okay? And then in late stages of OA, if it's getting really severe, using a gait aid or such as a cane or walker to unload the joint. And then for lumbar radiculopathy, maintain normal physical activity. Don't bed rest, okay? Keep moving. And I know I didn't include a lot for lumbar stuff, but if you have further questions about lumbar radiculopathy or low back pain, you can go on our, check out our Easthill Physiotherapy YouTube channel. You can find our previous workshops regarding, I did one on low back pain, so you can go check that one out as well. Yeah, go ahead and toss us a thumbs up, and if you enjoy what you see and you want to watch more awesome videos, subscribe so you don't miss out on the future content. Okay, so let's chat. What is your biggest takeaway from the workshop today? Type in the chat, I want to know. Hopefully everybody learned a little something and we were able to kind of give you guys a self-diagnosis and a way to help treat it. Don't stand with my hip popped out. Beth, yeah. Good exercises. I think it's more my lower back than hips. Interesting, Shelley. Avoid being sedentary. Sandra, that's a good one. Again, pillow under the leg for side sleeping. Awesome. Oh, Beth wanted to know, can you have a tight IT band or is it the greater trochanter? So yeah, you can have a tight IT band. Yes, but it's a very thick tendon sheath, and it's very hard to make a change. I know a lot of us just roll it and stretch the heck out of it, and it doesn't make much of a change. So what actually works really well is getting the glutes just the way that the glute attaches into that TFL IT band. So what happens when it's tight is it kind of slips forward, and then you get that slipping and pain, right? So what's better to do is actually strengthen the glutes to pull that IT band back into a nice alignment, so then you don't get that snapping. Stretch before exercise. Good to know what to focus on with OA. Yeah. Tenderness, not easy to deal with. How to work with it. I no longer think I just have OA. No. Oh. Candace, confirm my condition and I am doing the correct exercise. Beautiful. I love to hear that. Nice. Well, awesome, you guys. Awesome. Cool. Well, I'm glad everybody learned something. So tonight, we've provided you with a self-diagnosis and, what's been causing your hip issues and ways, you can begin treating it. So if you need further help, feel free to reach out to us. We're here to help, okay? Please type hip in the chat box, and one of our Easthill physiotherapists will follow up with you in regards to any concerns or questions that you might have. So if you do have questions, concerns, type hip in the chat, and we'll get a hold of you, okay? Just so everybody knows, if you are, having concerns, we're offering free 15-minute talks to help you get the answers you need quickly and get back to, doing what you should be doing. You're skiing, you're hiking, you're walking, right? And then if you're really having issues and you're like, Braden, I don't know about this, then just, you might need a personalized program, so you can go ahead and book a full assessment with us, okay? So I want everybody to watch your emails on Friday for the links to the video recording of today's workshop. And you'll also be getting a handout of that guided self-diagnosis you can go through again, and then the exercise PDFs for each condition, okay? And then I want everybody also, there'll be a post-workshop survey that's going to be in the email. And yeah, it would mean a lot to us if you could fill that out. It's, it's the best way we can improve and make our workshops better and, find out what you guys want to see in future topics. I know everybody told us they wanted to see some hip stuff, okay? So that's why I did it. So let me know. I want to know what you guys want to know. And then, for future topics, keep your eyes open for our next upcoming workshop in March. We're going to be going through some knee pain, so that will be coming up. So exciting news for that kind of stuff, okay, you guys? So now that we're all done, you guys are very welcome. Yeah, I appreciate it. Yeah, thanks for coming. So let's open up some of your burning questions. We got a little bit of time left. Let's go through some questions. If anybody wants to hop on mic and has a burning question, feel free. Valerie, can you go on mic? Maybe you're muted. I don't know. Try the mute button there.
Well, only if you want to address the fact that I was to a 𝗬𝗂𝗃 chiropractor a few days ago, and driving home from Kelowna, I was getting running pains through the same spot that I do get pains in my hip, just up above my buttocks.
Interesting. What did you think with the self-diagnosis? Did it kind of identify anything for you?
I'm the last three. I can't remember the names, but pink, green, and whatever the last three, purple, I think it was.
Yeah. Okay, so maybe some lumbar stuff relating to some hip dysfunction. Mm-hmm. I find a lot of them, they're very similar, a couple of them, right? There's a couple that it's hard to distinguish, but, there's a lot of those exercises, aren't going to hurt to do any of those for any of those conditions, or shouldn't. So, yeah. Well, it's very nice to see you, Valerie. I haven't seen you for a while, but thanks for coming.
Well, you will again sometime, I'm sure.
Okay. Well, let me know if you need anything, okay? I appreciate you coming.
I will.
Okay. Okay, anybody else have a question for me? Okay, well, awesome. Yeah, thank you guys again. And so hopefully I'll, see you at the next virtual workshop. And if not, hopefully I'll see some of you around the clinic, or if I see you guys around the community, come say hi. I wanna meet everyone. Okay, thanks again. See you in March.